Dear all, welcome back to this new episode of the interview of the faculty members for the next Ven in Venice. And I will start this episode by saying that about 15 years ago, I started watching his video content on YouTube, just to look and learn from an expert the new techniques that were coming out, such as local ablation, glue occlusion, and other technique. I enjoyed his video, really full of content. And probably he was among the first to understand the importance of training and dissemination through the web. At that time, I got to say that I was not, confident that one day we will be together for an interview, because he has been a guide for me in research and clinical practice. So I don't want to waste any more time. It's with great pleasure and honor that I welcome Professor Mark Steven Whiteley. Hello.
Hello there, Luca. Thank you very much, and thank you for such a kind introduction.
It's my pleasure, and it's my thought. I would start this interview as usual by starting from the beginning of your career. And you have graduated and specialized in general surgery with a fellowship in vascular surgery. And my question is, at that time, how did the idea of dedicating yourself in the venous field came about?
It's quite interesting. I regarded myself as a bit stupid when I was a medical student, and so I was going to be an orthopedic surgeon. And then slowly, as I went through my career, I actually got told I was a bit cleverer than I thought. So one thing led to another, and I loved general surgery, so I started doing that. And then I got an opportunity to train with Professor Michael Horrocks, who is a wonderful surgeon in arteries down in Bath, and I did my thesis. And because of my research, I ended up in Oxford University as a lecturer. And when I was in Oxford, I'd always been interested in veins, because when I was a medical student, I kept asking questions, and people would say, I'd say, well, how do veins work? And they'd say, well, it's the valves. And I'd say, but how do they work, when you have the leg pumping and stuff? And everyone would just get frustrated and say, look, it just works that way. And I realized that nobody really understood them. And then by the time I got to Oxford, we used to spend a lot of time, the senior doctors, we'd be in a room with 6 artery patients, an aneurysm that had been done 2 times before and had an infection, a carotid that had been done 1 time before. So really complicated patients, all about 80 or 90, all who were going to live or die. It didn't matter if you operated or not, and all going to cost the government tens of thousands of pounds. And I'd look out through the door, and there would be 100 patients in their 20s, 30s, 40s, 50s with a long time to live, all with vein problems, who were being seen by the most junior doctor who knew nothing, who either said you have a strip or you don't have a strip, but they didn't really know. It was just, hitting guidelines really. And a nurse going around with them who didn't have a clue. And I suddenly thought to myself, those people out there, you're going to do something to them. And if you do it badly, they're going to keep on coming back year after year and year, or have problems. And if you do it well, you could actually change the quality of life for a lot longer. So what really made me go into venous surgery was the idea that I felt you could do more good for people for longer with less money than the sort of heroic things that vascular surgeons love doing. And of course, now that was my idea back in the 1990s. And now, of course, the NICE guidelines have shown that in fact, venous surgery, you get more good health per year for each euro or pound spent than anything else. And it actually is the most cost-effective treatment. So what started off as sort of my inkling of trying to do the best for as many people, and then the science side is just fantastically interesting, has now been shown to be the right way to treat people. It's just, of course, that unfortunately, as we all know, with politics is not as sexy as cancers and children and everything else. So veins are still, it's one of the most important health problems we have, certainly in the Western world, and a lot also in the third world with the ulcers, etc. But it's still largely overlooked, both by funding bodies as well as patients.
Yeah, totally agree with you. Thank you for this really nice point of view that probably everyone should hear and take it some time for the consideration. Now I will talk about another chapter that I would call first, international and national first, but I have to read because there are a lot of first. So you have been first endovenous thermal ablation in UK, March 1999, first endovenous perforator closure in the wall, TLOP technique in 2001, first description of saphenofemoral thrombus and endovenous thermal ablation, subsequently called by Professor 𝐕𝐞𝐢𝐧 heat thrombosis, and you did it in 2004. And then first description of difference between thrombotic occlusion, leaving vein wall skeleton, and ablation by transmural death in 2004. First endovenous microwave ablation of varicose veins in the world outside of China, February 2019. And the first high-intensity focus ultrasound sonogram closure of varicose veins in UK, and second doctor to use the system in the world, May 2019. So that's impressive. I got to say this. So my congratulations for all these, achievements, but also thank you because I think that all of this helping the scientific community to grow and this sector to, to move forward. So the question that really comes from the heart is, what drives you to be the first to explore, a new idea or a new technique?
And that's a really interesting question because and none of those cases did we sort of set out to be the first. It's just that what we had in front of us was a problem, and in each case it was the obvious thing to do. So back in the end of the 1980s, early 1990s, I had a very good friend called Dr. David Prithook, who was a vascular scientist in Portsmouth when I was a registrar. And we spent ages talking about how terrible it was to cut in the groin and tie veins off, because we could see they grew back again. Although nobody had really proven neovascularization in those days, it was obvious it happened. So we were talking and saying, the groin's dirty, it's, more infection and it's painful. So we were trying to invent ways to put something into the vein at the bottom end, go up to the top, and then do something to the vein on the inside, because it was the logical way to do it. And unfortunately, I never thought of heat. So we invented lots of little hooks, little ties, and lots of different things to try and do it. And in the end, I sort of gave up because we couldn't work out how to do it. And then when I was a consultant in 1998, I got this phone call from a company, and they said that they had this product, and it was a balloon, and it's that. And just as they're about to put the phone down, they said, "Oh, it's a shame you don't do any varicose veins because we've got this new radiofrequency venous closure." And I said, "Well, what do you mean?" They said, "Oh, it's a new technique, and you cut in the groin, tie the vein off, and you put it down, but it replaces the strip." And I went, "No, no, no, it's a perfect thing. You put it in the knee and go up." And they said, "Oh, you can't, it's dangerous, etc." So I said to them, "Send it to me and I'll do one for you, because it's obvious this is the best way." And they said, "Well, we've already got some professors who are, going to do it, and some other people do." And I said, "Fine." I said, "When did you give it to them?" They said, "Oh, 6 months ago." And they said, "Have you done any cases yet?" They said, "No, they're looking for the right case." I said, "If you give me one next week, by Friday, I'll have done my first case." So that's how that happened. Then, of course, when we got very good at doing this, we were the first in the world to do 1,000 cases, Judy Holdstock and I. And in those days, we knew perforators were important. Most doctors still argue, but we already knew, and we were doing septs. So we had this perfect way of doing the great saphenous vein and small saphenous vein with a needle hole, but we were still then making a 2-centimeter incision for septs. And so Judy and I said, well, we were talking one night, and this was actually in 2000. I know it's quoted 2001, 2002, because that's when we started publishing. But in 2000, we were looking at each other and we said, well, we want to close the perforator. Why don't we do it with the same technique? So we just turned the device around, put the ultrasound on the first time of closing a perforator in 2000 with the radio frequency. And then we spent about 6 months discussing on what we should call it, and we ended up with TRLOP, trollop, transluminal occlusion perforator. We did as a joke, because trollop in English is a rude word for a lady. We did as a joke, and of course Steve Elias and the Americans don't like that because it's a rude word, but it's 1 o'clock in the morning and we've been working all day, so it was funny in those days. And the other things like the 𝐕𝐞𝐬𝐧, when we first described that was actually 1999 we found that. And it was purely and simply that Judy called me and said, "Oh my goodness, I think we've got this clot, it's just waving in the wind." So we took the patient straight back to theatre, and it was only in 2004 when I was writing my chapter for the book for Charing Cross. I thought, oh, that was an interesting case. I'll just write it as a potential complication. So that's why the publication came out. But it's actually 5 years after we discovered it. And what's always interesting is it's not. I mean, number one, lower Cabinet's got the fame for giving it a name rather than being the first to describe it. But the other thing is they're always concentrating on what it looks like at that end. What's the important bit is, number one, can you prevent it? And I think we can by doing closing the vein at the right point, which is slightly different from what Lowell and the other people are doing, leaving longer thing. I think you should leave no turbulence, but that's a technical story. The other thing is also what's happening at the other end. It's not the top that's waving that's important, it's how long is the thrombus. Because if the whole great venous vein is thrombosed, and that's all going to go to the lungs, you've got a big pulmonary embolism. If it's all ablated and you've just got a little bit of thrombus, then of course it's not so much of a problem. So I think some people, sometimes when you have people jumping on bandwagons and not thinking scientifically, you end up with people sort of looking at the obvious bit and trying to classify or talk about it, where in fact what you should be thinking about is the whole disease progress. And the same thing came, I used to get fed up going to conferences where people were talking about, we're closing veins by destroying the endothelium and sticking it together, when that clearly wasn't the what's happened, because thrombosis doesn't close a vein when you have a cannula in. So, the idea of the thrombus versus fibrosis, we did a bit of research, prove it. But, to me, a lot of these things are, some of the things I publish are what I think is common sense. Some things are, patients come to me and say, I've got this problem, or I can see a problem that he's treated, and there is nothing. So there's nothing to offer them, or there's something complex to offer them. And so what drives me really is trying to do the best for the patient. And in a way that what a lot of doctors will do is they'll say, there's this problem. They'll find something that's really difficult that nobody likes doing, and they'll just practice and practice to get better and better and better. Whereas I'll say, well, let's invent a new instrument, or let's invent a new technique, or let's find a better way of doing it. And some conditions, people say, oh, we just can't treat those. Well, I think nowadays with science, we should just keep on pushing and pushing until we find those areas that we can treat. So at the moment, we're doing we're about to publish a whole load of things on Klippel-Trenaunay syndrome and how best to treat that. And then some of the new facial vein aesthetic phlebology, we've got all these new ideas and inventions coming out for those. And sometimes it's, instead of just taking what we think we know and trying to push it a bit further forward or practice more, it's going back to the biology and saying, what's the science behind it? What's the science behind the condition? What's the science behind what we know we could treat it with? Try and put them together. And if there isn't something there now, let's invent something new, or a new technique, or a new way to do it. So it's really driven by what the public or the patients need, and then sort of going through to give the safest but most effective way of providing that service.
Yeah. Thank you for this answer. And probably it's now better. It's easier to understand that you were not looking to be the first. You were looking to find a solution for the patient that was less invasive, more effective, and that's what drives you. And thank you, and I agree, of course. The next question, it's something related to the be the first, but anyway, concern about the concept of vein clinic, and probably in these two, you were among the first in Europe to conceive the idea of a clinic dedicated to the venous treatments and venous disease, And of course, over the year, your group has grown, and probably now you are among the first, or among the first and the world leader in this sector. So the question is, what advice would you give to a colleague that who'd like to undertake this path, and an advice? How do you set up your business in this sector?
Well, the first thing I must say with this one, I stole the idea from Jose Imelda and Ed Mackey and some of the originators in America. I had been traveling a lot in Europe, and it was quite interesting because in Germany, when I used to work in Hamburg, I used to go there for some fellowship that I won with a lovely man called Gunnar Rieper, and who's a vascular surgeon now in Schaffhausen. And his boss at the time, Professor 𝐕𝐞𝐢𝐧, and Professor 𝐕𝐞𝐢𝐧 once said to me, he said, we should stop thinking about the hospital, because for every 100 patients going to hospital, if they start to walk out the road, 70 of them should be going to local anaesthetic clinics on the way to hospital. And then I spoke to an insurance company in the UK shortly after that, and they said we see a waste of money of people going into a big hospital because it costs money to have the nurses and the infrastructure. We would much prefer local anaesthetic clinics, but doctors are just caught into this idea that it all has to be done in a big hospital. So way before I even went to America and saw the vein clinics, the seed was already there that the way we should be doing it. It's like dentists. You know, dentists have their office-based practice and have for years. So it's not really a big change if you think of dentists. It's only a big change if you think that doctors don't do that. I think the difficulty with it is that it comes down to doctors are not good businessmen generally, because businessmen have to not trust other people. They have to really go against the grain. They have to find a USP. They have to find the marketing. They have to fight for the position. They have all those sorts of things. They have to also work with other people. You have to. It's very, very important that when you find the people who aren't competing with you but want to work with you, you all share and you help. It's completely reverse for doctors. Doctors compete between themselves. They never share anything. They only think about sort of outcomes and what they look like, and they don't think about money. You know, we all know in the systems, they pick up one needle. I don't want that, throw it away, pick up another thing. They don't think about money at all. And they also trust people. They trust patients. Patients tell them something. We all get very upset when a patient lies to us. We call it 𝐕𝐞𝐢𝐧. You know, we hate it. So the skills to be a good businessman are totally at odds with the skills and what you learn to be a doctor. The personality types are different. And I think one of the most important things is to recognize that, because what you do is don't try and do it yourself, but to bring people in around you. I didn't do this early in my career, and I'd be more successful if I had of. So this is advice from many years of getting it wrong. And surround yourself with people who fill in your gaps. So none of us are great at everything. You've got to say, and you know, I'm good at research, I'm good at talking to patients, I'm good at operating, luckily, all those things. And I've got the basic idea of business, but you know, I don't understand finance so well, I don't understand marketing. And so over the years, I've learned, and even right down to organization, I've got the superb director of operations now. And I bring people in who fill in my areas. And I also have the ability to turn around and say, this is not my specialty, this is yours, and to give up that position. And because of that, our clinics are now expanding faster than ever before. I think what you have to do is I mean, we could do a whole week's course on business, so it is difficult. I think just a few little nuggets I've learned along the way. There's only two businesses you can have. You can either have what's called a lifestyle business, where you do as much work as you need, you get money in, go home, don't want to work this weekend, I'm not going to work this weekend, and you have a nice lifestyle business. Or you have an exit business, and that means you put all your time in, all your effort in. You work weekends, you work nights. When you earn any money, you put it back into the business. You keep reinvesting, because your income is going to come at the end when you sell out, and that's called an exit business. What a lot of doctors do is they try and do a bit of both. They want a nice lifestyle. They don't want to work too hard. They want to say no to places. They don't want to give up any control. But they still want to try and have a brand at the end of it, what they can sell. And the two, you just can't you've got to set your mind on one of those and always go. You can't swap. So if you're going to hire a room in a hospital and you're going to always hire bits out, you're probably never going to be a true brand. You'd have to make a good business case for that. What you really are, there's a lot of people in England who go to a private hospital. The private hospital say, oh, you know, for £1 a year, we'll let you use this, but you still got to use our pathology, and you've got to use our this and that. And they call themselves a clinic. And of course, the day they're not working there, the signs get taken down. It's somebody else's clinic that day. That's a private practice. That's not really a clinic. What you need to do is, once you start renting a place of your own, or renting a place in the hospital, it might be, but it's always your brand, you know, and you control the income, the expense, you control the business practices, you do the negotiation for the laser fibers or the you know, sclerotherapy. That's then when you're starting to make a business. And I think that's the most important thing, is decide, are you a lifestyle where you're going to just do a bit of rental when you want to, and you're going to flit around and someone else is going to control your marketing, or you're going to be exit, in which case you control your brand, you control all the quality, and you're really just, the only thing you'd ever hire is maybe the floor area, and the equipment, and you're the person who's going to pay for the nurses, the assistants, the colleagues coming on board. You're going to set up the business structure, and I think that's the basic idea. And then once you've decided which of those models you want, then there's lots of different ways to run it inside, but you've got to have made that first decision. Is this going to be my life? Is it going to be a 20-year climb to make a big business, or am I going to have a lifestyle business, let other people do the work, and I'll just take my professional fees?
Yeah, I think it's really interesting topic, and in other business we have a lot of book and course to understand better how to do. As you told before, we are doctors, and we came from other studies, and we don't have the skills, and at the beginning we don't understand completely how to create a business, and probably you should write a book on that. Or
I've started several times, but unfortunately, fortunately, I've ended up writing books on veins instead. I find it easier.
Because you're a doctor, that's the problem. Well, let's move now to another topic that I'm really, it's a topic dear to me. We talk about now a little bit about scientific research. To get prepared for this interview, because I did it, I wanted to do a good interview with you. So I type your name on PubMed a couple of days ago, only on PubMed. Now Cochrane knows Google Scholar, not the platform of the College of Phlebology. We will talk about that later. Type your name, and I found your name in more than 80 publications. So again, it's impressive, because I know the work that it's behind to create a work, a study, the process, and also the when you finish the work, the time that you need to be under review and whatever. So it's really impressive. My congratulations. And the question is, how is important the research for you, and how much time do you manage to dedicate each week to the research?
Well, if you wrote �W𝐻𝐼 MS, you should have found 150 publications.
Okay, yeah, probably a wrong type. Wrong type.
It is difficult. For me, it is when I die, the only thing that will be left behind really is publications. And for me, I was sort of brought up in the idea that it was publish or be damned, and publications to me are probably, in peer-reviewed journals especially, are probably the most important things we do as doctors, because it's how you communicate, it's how you influence people who are generations away from you, who are miles away from you, who've never met you. And the peer review system, although it's not perfect, I've had many very good papers rejected by doctors who just didn't understand the concepts. And some of them I get published elsewhere, some of them I just give up. And it's a shame, because that means sometimes for jealousy or other reasons, they don't get published. And that information therefore doesn't necessarily get out. And I think we should publish because we're trying to get information to our colleagues, not just because we're trying to, increase our CVs. I think it's to make this body of scientific work, and it's all my publications are related to something that's going on in my mind as to why I treat the patients. There's a second thing as well, on a personal side, and I think this is very important for all of those of us like yourself who are trendsetters in your area. We all know that our colleagues can be very jealous. And we know, until people know, lots and lots of doctors will say, "Oh, Mark Wiley, he's this, that, and the other." Will say horrible things about me, and you'll see some of them on the internet and stuff. And then if you ask them, have you met him? Have you been to him? Oh, well, no, or yes, well, I met him at one. They don't actually know me, and everything is doctors are jealous of people who are successful, and so the only way you can protect yourself is by publication. I've got some very, very good colleagues. I've got one in particular, and she's a brilliant doctor in her speciality. She had some amazing ideas, which were world beating, but she never published. And she got chased out of her speciality. They called her all sorts of names, and they made her life very difficult, because when she was criticized, she didn't have any figures to prove it. She just was doing her things. And I think there's two bits to that. Firstly, she couldn't prove what she was doing. The second thing, I don't think she had formulated in her mind until you do it as a research project. You think you've got an idea, but until you research it, you might think, oh, I wasn't quite right. It's, you know, these patients, you can't do that. You have to formulate and you have to structure in your mind what it is you're trying to prove. And then does the science support you? So it's a learning process as well. So I think for protection, like this poor lady, you know, what's ended up happening is all her ideas have been stolen by other people because she never published in her specialty. I think what's important is, you know, if you believe something, you should research it. You should do a proper structured study with others or not. And you might find, to a shock, you might find that you're wrong. And you have to be brave enough to say, actually, gosh, you know, I wasn't right. Because every good research paper you write will lead to 3 or 4 new ideas, because as you're doing it you think, well, what I didn't check was this, that, and the other. So your depth knowledge gets deeper and deeper and deeper the more research you do. And from my point of view, and I think you know this very well as well, I don't think you truly understand any subject until you do 2 things. Number one, teach other people, because they ask you questions that you weren't expecting and you have to think on your feet. And number 2, do research to prove what you're saying. So you say, I believe this, and here is the research to back it up. Or I used to think this, and here's the research which showed I wasn't right, and I've modified it, and now this is what I believe. So I think research is, if you're going to be at the forefront of your speciality, and you're going to be a teacher of credibility, I don't see how you can do it without research. I think research becomes an essential tool to make you into the professional you want to be as a phlebologist, because there aren't enough textbooks in enough detail. You can't just read it all. You have to actually be at that stage of coming out with novel ideas and testing them.
Yeah, you're right. And probably you also touched the point by talking about peer review and that process. So probably in this direction, you decided to move with the preprint service to allow the opportunity to everyone to show their work, their paper, and then of course the community will judge the type of the value from the scientific point of view. But it's a way to tell the people, let's work in this direction with scientific, rules, and show us if your concept has, some roots that are scientific. And so I think this is probably the future also,
Yeah, totally agree with that. I think, the idea that somebody is going to, an editor is going to take 2 people who are, so say, experts in an area, and their opinion, maybe a third on top, as to whether you should be published or not, is quite ridiculous, because we all know that those of us who, I'm sure you have it yourself, we all have colleagues who hate us because we've put our head above the parapet and we're doing something different. And so sometimes the rejections come through, and when you read them, scientifically that they're completely wrong. And there's no credit in that review. My feeling is that peer review is on its way out. I think we already know that the court of public opinion in social media has become very important for everything else. What we need to do is, in the preprint server type thing, I think what we're going to do now, and there have been a couple of journals that have tried this for open review, where anyone can review it and anyone can write. The one thing that hasn't been sorted out yet is, of course, we know on the normal internet about trolls, people who are uneducated, who just want to make a point, sometimes have got an axe to grind. So it is difficult if you just open up and say anyone can comment. So I think peer review is one extreme, where you're putting somebody's your work into the hands of 2 people who anonymously can reject it. That's clearly not right. Then there's not a good right of appeal. I've had some amazingly bad letters rejected by work, and you just have to go to another journal and say, this was said elsewhere, but it's clearly wrong, or argue with the editor. But it is difficult, and as you say, time consuming. The other end is, you don't want to open it up where people who have no knowledge at all about the science can just comment and make silly comments, or people can do it nefariously. So I don't sort of, there's going to be somewhere in the middle where your peers, but all of your peers, can actually make sensible comments. And at the end of the day, I think that it might even be that they don't make comments. It might be like at the peer review at the moment in the College of Phlebology preprint server. What we do is papers get put up there, and people can take that information. They either use it or they don't. You don't necessarily have to have a thumbs up or thumbs down. It's, you know, you're putting it out into the scientific community. If people like it, they will use it and quote it, and if they don't like it, they won't. And the great thing with preprint server is it means it's free. You can get your information out there today. You can put it in there today, and provided it is relevant, within 24 hours, it'll be on the internet everywhere, not PubMed, but it'll be on Google Scholar, it'll be everywhere. If you decide you don't want to publish it elsewhere, can't go through the hassle of peer review, that's fine. Or if it's rejected, you know, it's still out there. But if you want to peer review it, it doesn't stop it. It's just when you go through the peer review process, it says, have you put this on preprint server? You just say, yes, here it is. And then all you do is when that gets published in the peer review, you just then put on your preprint server, this is awesome. And you just put the reference to the other. So people can see, and it's quite interesting sometimes because your preprint one has quite often been changed by referees' comments. So sometimes it's quite interesting to read the paper that was published versus the preprint version and see what the referees demanded to be removed.
Yeah, you're right. Well, anyway, I also advise everyone to use the preprint service, and you know, as you told, it's free, but also it's not something that block you for, you know, submit your work in other, you know, peer review paper journal. So use it. And so now let's talk about College of Phlebology. Of course, you are the founder of this great, you know, scientific community, scientific society, I would say, with numerous members inside, and a really excellent scientific board. And about that, not about the excellent, but about the scientific board. Thank you for involving me, of course. My question is, what drive you to undertake this enterprise? You know, you are a great surgeon, a great expert, opinion leader. You have your clinics, you have your research, a lot of things to do in your life, and you decided to you know, to undertake this enterprise. So a sense of community, or it's the desire to push forward this sector. What you can tell me?
I think it's both of those. I think it's a sense of community amongst those people who are truly interested. My difficulty is in the UK. There's almost no one I can speak to who really understands veins. I can teach. Most people don't want to learn because there's no position in the UK called consultant venous surgeon. So most people are vascular surgeons who are still struggling with the thought of, you know, great venous, small venous should be called that, and not long and short venous. On, you know, is the anterior accessory venous sort of really necessary? And you know, I was asked to be in a debate recently, well, about 4 years ago at the Vascular Surgical Society of the UK, saying, you know, are pelvic veins really relevant to leg varicose veins? And I was like, oh my God, you know, in 2019 we wrote the international guidelines, sort of explaining how to look at the treatment. And you think, are vascular surgeons that far behind venous surgery? And so, you know, it really is difficult. And certainly in the UK, there is no proper training for venous surgery. And it's all about artery surgery, with a few people sort of saying, oh, veins, it's, you know, over there. Whereas, of course, veins are far more interesting than arteries because, you know, there's the whole physiology and the reverse flow and, you know, obstruction and stasis. I mean, there's so interest in the area, and the physiology is so much more difficult than just something that pumps and either, you know, it's either blocked, narrowed, or aneurysmal. So veins are much more complicated, and of course affect more people, and have you know, a pathology at a younger stage, as we've said before. So the whole idea of the College of Phlebology, I was flying home from America in 2010 to 2011. And I sort of realized that the difficulty is there's a lot of places out there that call themselves either colleges or associations or forums that just are basically excuses for a meeting once a year, or they're the place to earn revenue. They don't really act in a way that's collegiate, that actually brings people together to promote and to increase understanding, and most importantly, they don't support. You know, there's not, it's you where you can put an abstract in, you can win a prize, or you know, you can do some online training, etc. But there wasn't any support. So I called it the College of Phlebology because the word college, you can have a college meaning a structure where you go to college, But the college in English is also, a second word is a group of professionals who are working together are called a college. It's a collective noun. And that's what the College of Phlebology is for me, is a group of professionals who at one level are exchanging ideas and help, and at another level are teaching the next generation or people who want to come into phlebology. And I don't want it, and I've never wanted it to be rigid. I've never wanted to say, you're a member, you're not a member, you've got to do this, you've got to do that. And I don't want to control people's practices and say, these are the guidelines you must do. I think once you get into that, you're becoming more of a regulatory body, and that's not what I want. What I've always wanted it to be is a mark. People who join it, there's one membership fee because we have to employ the people who run it, but once you're in that membership, there's no extra costs for the preprint server. Well, in fact, even non-members can use the preprint server, but there's lots of supports, there's WhatsApp groups, we have more and more courses coming out. A lot of them either free to members, or if they've cost a lot to produce, then are cut price to members. The whole idea, and then we have WhatsApp groups, as you know, for all of those people who've been on fellowships and who want to ask questions. And even this morning, I've had 2 questions from previous fellows who have got difficult cases who want help from. And it's not just my opinion. They can just ask me, but they can also ask anyone else in the college. So the whole idea is really a dissemination of ideas and education, and also supporting new ideas. There's a fantastic fellow, Carlos Durant, in I think he's in Paraguay, who's got a completely new concept of treating veins in a completely as part of the holistic view of the legs and the setting. And he's posting a lot with us at the moment. It's very, very interesting. There's a fellow, in fact, coming to your Veins in Venice meeting, who I invited, who I can't think from Singapore, I think, who's got a new way of imaging the pelvic veins. And so it's through the college that they contacted me and said, I've got this new idea, would you be interested? And then I sort of can help say, gosh, this is fantastic, or it's not great, but in these 2 cases, fantastic. And then I can put them forward and say, look, not only do I want you to help out the College of Phlebology to teach, but I can then say that there's this great meeting coming in Venice. I really think you should come. And fortunately, you invited me to be president of the veins section for the pelvic vein, so I could invite him as one of our speakers. So it puts his concept, which he's finding hard to get out there, he's going to put him on the international stage through your meeting. So I think the whole idea of the college is trying to just make that community of people who are truly interested in veins, both in promoting phlebology as a subject, but also teaching the next generation of phlebologists.
Yeah, the only thing that I can say is to invite everyone to join us in the College of Phlebology, because you can feel this sense of community, of course, but you touched the point before, it's saying that unlikely during the fellowship, during your university studies, venous field is something that it's not so understood at all, and the training is poor, and probably you miss something. And when you start doing your clinical sort of practice and surgery and whatever, you feel this, that you miss this part. In this case, you have a community that allow you to achieve all the information that you want, that gives you the chance to participate to symposium in which venous field is the center, is the heart, of the conference, and then also to join your course, to be trained with discount, So I think that there is no excuse now for colleagues that wants to be in the venous field not to join College of Phlebology. So please do it. And now let's move to the another question that, of course, will be based on the Vein in Venice Symposium. And of course, thank you because you honored me with the willingness to be part, not just at the faculty, but to be part of the executive board of the Vein in Venice. And this is a great gift that you did to me, of course, to all the people that will come. But in my opinion, it's really, really a great gift for me. And you have done an extraordinary work on the scientific program with really, really high level of content about pelvic venous disorder, and you have also involved a lot of great names. So really, really, thank you so much. My question is, what do you expect to see at the next Vein in Venice?
Well, you surprised me at the first one. So I came, I'd met you, and obviously I love your, not only do I like you as a person, but also I think your view is very, very good. You have a clear view of venous disease and where you want to go and how you want to train people in it. So I came to your first meeting, which obviously was much smaller, but you had a very, very good feeling in it. It was very supportive. It wasn't sort of saying yes to everybody. There was some good, robust arguments, but on the other hand, it was all about pushing forward. And then your second, the new meeting, obviously, it's expanded massively. I think when you have a good meeting and a good premise for it and good people involved, the word spreads quickly. And so your faculty this year and also the people coming is magnificent. It's what most people would expect at 10 years of a meeting. You know, you really have world famous people coming. And because of that, I think that and the great thing about it is some meetings have got are run by people who have very, very strong opinions on just one thing, like, you know, hemodynamic surgery or must be sclerotherapy, or, you know, must be surgical based or something. And sometimes you go to different meetings and there's a different bias. I think what's beautiful about your meeting is about phlebology. And I think it's a true meeting of minds. And I think, you know, this gives us the opportunity to actually discuss things that aren't discussed elsewhere. We've got some on the pelvic side. You know, we've got Alexandra coming, who doesn't believe you should be treating the inside pelvic, just the leaking points. And obviously that's not what I believe, but you should never argue. You should both put together your points as friends and say, you know, what's best for the patient, as we go right back to the beginning. And that's not just that. I think it's the same for the endovenous work, you know, and the whole approach, you know, the hemodynamic versus the ablative approach. I think, you know, a lot of surgeons, certainly a lot of surgeons in the Northern Hemisphere don't even know there's a hemodynamic approach. And I think it's really important that we have these opportunities of people who might have some more radical ideas to be brought into a supportive environment that's not going to ostracize them and not going to yell at them, which what we see all the time on the internet. And I've been involved in those discussions as well, because people get very, you know, sort of into tribes. I think when you go to an academic meeting like this, what you need everybody to be in a room and say, right, number one, first and foremost, the patient, are they going to get the best result? And as long as you've all got that as the thing, we're not fighting each other. What we're doing is we're saying, how can we give the patient the best result? And are the results you're producing better than these? And what are the pros, the cons, the costs, the risks? And that's the true scientific way. And I think, as I say, you know, my feeling with Veins in Venice first meeting was you're starting to really get that feeling. And as it gets bigger, the more we can keep that feeling going of being a community, of aiming to get the best for showing our own results. And of course, you know, we're all proud of our results, but also have that open mind of saying, you know, but what can we learn from our colleagues? And as I say, I loved your first meeting, and the way that the next one's sort of shaping up, I think it's going to be highly successful. As you know, I think my clinics are going to be bereft of doctors and vascular technologists, because I think half of our staff are coming to it now.
Yeah. Thank you so much for the kind word. I will go and cry after the interview for your for the job. Thank you so much. So let's move to the last question. No, you are busy man. So last question, then you are free. This is the question that I normally ask to every interviews, and it's about an advice. What advice would you give to a young colleague that starts now to, you know, starting his clinical practice and surgery on the venous field?
It's very difficult. I have met people from all around the world, so I know that this sort of advice is quite generalized, but I will give it mainly from the English point of view, because I think every country has slightly different views. I think the first thing, more than anything, is you have to have an ability to ignore some of your colleagues, because there is that feeling of, sort of veins being sort of just one up from Botox and fillers, but it's not as important as hernias, everything else, and people sort of almost feel a bit embarrassed when they're young talking about veins. Whereas, as a good friend of mine, Matt Thompson, once said, he said, medicine is a broad church. You should never look down on anybody else's speciality, provided you are using proper science, proper patient care, and are always putting the patient at the forefront. Then all medicine is relevant and should be taken with respect, provided you are using the principles of science and medicine to give the best for your patients. I think, it's now gone beyond that, because although people are rude about veins, we also know, as we said before, there's actually, you get more good health for longer per pound or euro spent than anything else. So I think it's now a legitimate way forward. However, certainly in England and in many places, the government and the regulatory bodies still don't recognize it as an end job. You have to be a private practitioner in England if you want to be a vein specialist, because if you're in the NHS, by definition, you're not a vein specialist. You have to do arteries with just a few veins on the side. And to get good results of veins, you have to be eating, thinking it, doing it all the time. You really need to, you don't really have time to also be thinking about research in aneurysms and bypasses, and that patient you're going to spend 4 hours with some, complex arterial disease. It's a full-time job. So the difficulty is, if you're a young person who wants to be a phlebotomist now, firstly, you need to be absolutely set in your ways. You say, phlebology is the way forward, and I'm going to put my life into that. The second thing is you have to go away from traditional training to an extent. If you just sit within your government training, your medical school training, you're not going to get good phlebology training. You're just going to get the sort of bog standard, I think the rep will help you with your laser and ready for it, and it's really bad. There's no conceptual ideas. And so that's where you have to be going to conferences. I started to go into conferences when I was an SHO. That's in England, a very, very junior job. And I started going just to listen. And slowly then I started to present as a registrar. And obviously you meet the right people. You're not just influenced by the people who are training you. You meet people who are international names, and you get to get into their heads quickly, and you get your concepts. So my advice would be, go to vein meetings early in your career, talk to people, get known by them, and then start looking for training outside. Start looking for courses that are going to give you qualifications or experience away from your mainstream. Do it as an addition to your medical school training or your surgical or radiological or dermatological training. And to an extent, we still have that position of largely being self-taught. I mean, one of the reasons we set up the College of Phlebology is to try and fill that gap, but we don't have all the courses ready yet. So I think, it's get into a community, get to the meetings, get to speak to people who are phlebologists, get known by them, get involved in research that might be away from your normal job, and get involved in learning courses away. And so to an extent, to be a good phlebologist now, it takes a little bit of your own, there's no route for everyone to follow. I think you have to keep your eyes open, and you have to be quite independent as a thinker.
Thank you so much. Personally, I will follow your, me too, your advice. Thank you so much for your time. And of course, I invite all the colleagues that are watching this video to join College of Phlebology, so this great community. And if you want to come and Vein in Venice and see each other in person. So thank you again, Prof, and see you soon.
Take care. Thank you.